My name is Sherif Andrawes. I'm the director of the Division of Gastroenterology, Hepatology, and Nutrition, and the director of Advanced Endoscopy Fellowship at Staten Island University Hospital with Northwell Health in New York. Today, I'd like to talk briefly about my article titled Top Tip Management of Esophageal Varices Not Responsive to Endoscopic Variceal Ligation, published in GIE. First, I would like to thank the section editor, Dr. David Deal, for his invitation to me to participate with this article. We provided a nice step-by-step approach with emphasis on resuscitation with restrictive transfusion therapy, maintaining hemoglobin between 7 to 8 grams per deciliter. Overtransfusion can worsen outcomes. Early use of vasoactive drugs like octreotide or proton pump inhibitors, antibiotics, and close electrolyte monitoring is crucial to improve survival. Second approach was, once the patient is hemodynamically stable, endoscopy should be performed within the first 12 hours. Preparation is critical. Proper protective equipment, CO2 insufflation, good suction availability, good water irrigation, and a therapeutic endoscope with a 3.5 millimeter channel is essential for both visualization, also for irrigation and suction, and for tool compatibility, particularly for deploying a self-expanding metal stents, if needed. Stress the importance of methodical inspection and localization. In recurrent bleed, it's often you will find a post-bending ulcer or a visible stigmata like a white platelet plug, or what's commonly known as a nipple sign. Document the location and the clock orientation within the esophagus to help guide future therapy, also in case of a poor visibility. We presented some therapeutic strategies. If the varices is still suctionable, we recommend repeat band ligation to be attempted. In case of a poor visibility or if there's active bleeding within the lumen of the esophagus, self-expandable metal stents can provide superior tamponade and stability. They can be placed through the scope on the spot. Highlighted the importance of pressure tamponade with esophageal self-expanding metal stents, SIMS. SIMS are highly effective for managing refractory esophageal variceal bleeding, especially in those situations with post-bending ulcers, in cases of brisk bleeding, in cases of poor visualization and localization. The stents can be quickly deployed to achieve tamponade over a long esophageal segment. They're superior to balloon tamponade that we will talk about later in terms of hemostasis and control of active variceal bleeding. Some technical highlights for the stent placements: do good pre-placement measurements in the lumen and the length of the esophagus to target the segment that you're concerned about. Know the areas of most concern for active bleeding and place your stent in those areas. Be very familiar with the available stents in the current market, the length, the diameter. The ideal SIMS should be the one that it's very easy for you to deploy. It has a good radial force, and the diameter of the stent is recommended to be more than 20 millimeter, with a length recommended to be between 12 to 15 centimeters to reduce migration and to have a good tamponade effect. We recommended that the distal flange of the stent should sit 1 to 2 centimeters below the GE junction to maximize compression and to prevent migration. It also can be very helpful in cases of combined esophageal and gastric varices. I highlighted in the article that it's very important that you plan your game or action plan, because you don't want one modality to interfere with the second modality if a second modality is needed. Meaning that if you place a stent early and prematurely and there is still bleeding from around the stent, it will be very difficult to use a sclerosing sealant through the stent, and localization will be very hard. If you are concerned about multifocal bleeding points in cases of severe portal hypertension, and you decided to use a hemospray powder, it's important that you apply the powder first, followed by the stent second. If you decided to use over-the-scope clip as a rescue therapy, it's important to use the clip first in a actively bleeding point, followed by a balloon tamponade therapy or stent therapy. You don't want one modality to interfere with the second modality. So planning of how are you approaching this bleeding, it's very important. In cases of refractory bleed, when the other modalities may fail, hemostatic powders with all its variety, or in cases of a persistent variceal bleed where there is gastric varices in combination with esophageal varices, glue injection can be very helpful. We spoke about that in the article. There were some limited case series of the utility of over-the-scope clip, the OTSC as a rescue therapy in this recurrent bleeding, and you will see in the article how was it utilized and the data on One of the important things that we all should be very familiar with is the rescue therapy with balloon tamponade, and this can be very helpful in a patient who's initially unstable. It can be placed in the emergency room setting, and it can be life-saving bridge in cases of these severe esophageal varices bleeding. At times, immediate endoscopic options may not be available, or that you need to get the patient to a stable point before endoscopy, and balloon tamponade therapy can be very helpful. So there are three primary devices that we talked about: the Blakemore tube, we spoke about the Linton tube, and we spoke about the Minnesota tube. And you'll see a diagram that highlights the differences between all these tube devices. Most commonly in all emergency room setting, and my emergency room setting, we use a Minnesota tube. And you'll see also that there is, a diagram to how to place the tube, how airway protection is always needed first and recommended, how the tube can be placed, how the tube has a gastric balloon and an esophageal balloon. There are multiple available videos online to show you how to use this Minnesota tube. It's very important that you become very familiar with it. Once the patient is stable, endoscopic therapy should be conducted promptly. Discussed that early referral for TIPS placement within 72 hours for those patients with refractory variceal bleeding and high-risk profiles, those with Child-Pugh B or C liver disease, that TIPS significantly reduces rebleeding and mortality. It's very important that this is discussed in multidisciplinary fashion with the hepatology team as well as the intervention radiology team. I hope this was very helpful. I would like to thank the team at GIE for the opportunity to provide some feedback on this article, and thank you all.